All right, so we're really here tonight, not for the comedy show, but for the serious subject of public health. And we're very pleased to have Ellen MacKenzie with us, and how appropriate that it's International Women's Month. So we have a woman who is the very first dean, female dean of Johns Hopkins Bloomberg School of Public Health. So I think that alone. She's the 11th dean of the school, which is the world's oldest and largest independent school of public health. She's a member of my class, the class of 72. I don't hold that against her. I didn't know her in school. I was sleeping in the library when apparently she was learning all the stuff she had to learn to go on to this wonderful career. She received her Bachelor of Arts degree in math from Douglas and a Master of Science and a Doctor of Philosophy from the Department of Biostatistics at the Bloomberg School. Dr. MacKenzie leads an organization that includes 700 full-time faculty working in 130 countries and teaching more than 2,300 students from 79 nations. Under her leadership, the school seeks life-saving solutions across a broad range of issues, from chronic and infectious disease prevention to immunology, nutrition, and child survival. In 4 decades with the Bloomberg School, she has been a transformative researcher and leader, acquiring a deep knowledge of the school's mission, curricula, and faculty. She's a leading injury prevention expert. She was named a Bloomberg Distinguished Professor in 2017, joining a group of world-class faculty leading interdisciplinary scholarship at the university. The appointment recognizes her achievements in trauma care and rehabilitation and supports her continued work in these areas. Early in her career, Dean MacKenzie trained as a biostatistician and developed a commitment to evaluating and improving outcomes following trauma. She has helped define the field of trauma services and outcomes research and has long been recognized as one of the foremost experts in this area. Her research has focused on documenting the impact of health services and policies on the physical and mental health consequences of traumatic injury, advancing knowledge of the economic and social impact of injuries, and understanding of how personal and environmental factors influence recovery. Dean MacKenzie has authored more than 250 publications and co-authored, along with Dorothy Rice, The Cost of Injury in the United States, a comprehensive effort to estimate the direct and indirect costs of injury. The book was, for many years, the principal resource on this subject. In addition, she authored the National Study on the Costs and Outcomes of Trauma Care. The Centers for Disease Control and Prevention named Dean MacKenzie one of the 20 leaders and visionaries who have had a transformative effect on the field of violence and injury prevention in the past 20 years. She served as president of both the Association for the Advancement of Automotive Medicine and the American Trauma Society. Now that we have no time for her talk, we'd like to thank her for being here. It's not my fault she's this accomplished. Please join me in welcoming Dean Ellen MacKenzie.
Well, it's a pleasure to be here. I am just so thrilled, and I'm so thrilled to see some of my classmates from Douglas, from the class of 1972. It's just wonderful, wonderful to be here. And I'm particularly honored to be here to give this Zagoren lecture. I do remember your mom. I don't know if you guys remember her, but she was a force, and I remember as I guess it was more in maybe my junior or senior year. I mean, she was already starting to recruit alums as you finished up and ready to go out and be alums. But I remember her very fondly. So it's a particular pleasure to be here and to give this lecture in her honor. So thank you for that. I'd also like to acknowledge a fellow alum who I've had the pleasure of getting to know over the last few years, and that's Kathy Ludwig. Kathy's known to a lot of you in this room. She's a good friend and supporter of Douglas College, but she's also a very good friend to the Bloomberg School of Public Health. Her passion and commitment to human rights led her to our Center for Public Health and Human Rights. where she became the inaugural chair of our center's advisory board for that particular center in 2008. And then 5 years later, she joined us as a member of our health advisory board. And I am just so pleased to have her on this advisory board. This is the group that I've had the pleasure of working with over the past year and a half as dean, and she's been a wonderful source of support, advice, and friendship. So thank you, Kathy, for being there. So I thought I would just take a few minutes and talk a little bit about my journey from Douglas to being a public health dean. I chatted with a couple of you over dinner, but just to give you a quick snapshot of how I got from there, or I can't say from there to here to there. But as was said, I majored in math when I was here at Douglas, and I got a great education at Douglas. It really prepared me well for everything I'm doing now. But when I was getting ready to graduate, I sat down with a counselor and said, all right, what do I do with a math degree? And I was given a couple of options. One was to become a math teacher, which was very attractive to me because I come from a family of teachers, and that was definitely an option. Or I could become a computer programmer. And those of you who can remember back when, so a computer, it was like a whole block long, right? It was crazy. But at that point in time, computer programming was just becoming a thing. And so everybody wanted a computer programmer, and I guess as a math major, that trains you well for programming. But that didn't intrigue me all that much. I was also given the option of being an actuary. Yeah, really. And the worst part of that is they said, well, you have to take this series of 10 exams in order to become, a well-regarded actuary. That didn't seem like so much fun. Or I could go to graduate school. And I said, I know how to do that. I know how to study. I know how to go to school. So I went to the library and went through all these graduate school catalogs. And I was looking at math programs, because that's what I did, was math. And I thought, well, that would be interesting, but what would I do with a PhD in mathematics? And so I kept looking, and I stumbled across this field called biostatistics, or biometry. And that intrigued me. Now, mind you, I had not taken biology. So I took physics when I was here at Douglas. I had not taken biology, and I had not taken any statistics. And yet, the field of biostatistics was appealing, and because it gave me something to do with my mathematics training. And so I thought, well, gee, I'll try this. And I applied to a whole bunch of biostatistics programs. And I'm not sure why Hopkins accepted me, because I had no biology or statistics, but they did. But they insisted that I take a biology course my first summer when I graduated. So I came directly from here in 1972 to a summer program in biology at Johns Hopkins, and have been there ever since. But it's great. And when I went to the School of Public Health, I sat down next to my classmates, and I was sitting next to health ministers. I was sitting next to mid-career health professionals who had already made a commitment to public health. They knew why they were there, and they were just there to kind of broaden their horizons, hone their skills. I was there searching for a way to use my mathematics and my problem-solving skills that I loved, and I was looking for a way to apply them. And I found that way, fortunately, and the rest is history. I went in and out of doing research, and that's my first love. I love doing research, but I also had opportunities along the way to work in academic administration. I ran a center for injury research. I was an associate dean for a while. Then I was a department chair of our Department of Health Policy and Management. And a year and a half, almost 2 years ago now, 2 years ago, I stepped down as chair of our department. And I was really looking forward to getting back to my research full time. I thought that would be great. No more administrative responsibilities. I'll just sit back and do my research. And then this opportunity came along to be dean of the School of Public Health. This was not in my plan. I was not looking for this, but the opportunity presented itself, and I can tell you, it's the best decision I've made in my life. It's re-energized me, and it's the former dean of the School of Public Health says it's the greatest job in the world, and I can say that now. It's amazing. The school is it's a great place to be, and I feel very, very, very privileged to be part of the school for so long and now leading that school. And it all started here. So when I was preparing these remarks, it dawned on me that both Douglas and the Bloomberg School of Public Health celebrated their 100th birthday in just the last couple of years. So Douglas celebrated its 100th birthday last year. We celebrated our 100th birthday 2 years ago in 2016, although we didn't admit our first students until 2018. 100 years before that, 1918. So we're lock and step. So that was pretty interesting. But I will also tell you that it did not. It was obvious to me that the Bloomberg School at Johns Hopkins was a little bit behind Douglas College because, as you all know, Mabel Smith Douglas was the first dean of Douglas College, and she broke. I was reading about her, and it says that she broke the ceiling, the glass ceiling. Well, it took Hopkins and the Bloomberg School 100 years to break that ceiling, but they did it. And as I said, I became the first woman dean about a year and a half ago. I will also note that when I started out in public health in 1972, there were about 20, maybe 25 schools of public health. Today, there are over 60 schools of public health and over 120 programs of public health. So the field of public health has grown enormously. In fact, when I was at Douglas College, I decided that I would go to school in public health. I looked around for courses in public health and found one course, but it was a very, an introductory course on really the rudimentary aspects of public health, talking about sanitation, rodent control. But I took it, and that was my introduction to public health. Now, Rutgers has a whole school of public health, and I learned tonight it has a very vibrant undergraduate program in public health as well. So, what is public health? Well, public health is all about protecting the health of people. And it's protecting health of people, not one at a time or two at a time, but many at a time, populations, the health of a city, the health of a county, the health of a nation, the health of the world. But it's all about protecting the health of populations. And the Institute of Medicine, back in 1998, defined public health as what we do together as a society to ensure the conditions in which everyone can be healthy. And our mission in public health is driven by the public health approach to problem solving, which espouses a dynamic process of science informing policy and programs, and practice, policies and programs, informing questioning science. And this is done through a set of core activities, namely assessment, application, and assurance. So in terms of assessment, we start with defining the magnitude of the problem, and I'm going to move this a little closer here. It starts with defining the magnitude of the problem and the determinants of the problem. Why do we have the problem? What is the problem? Why do we have the problem? Then it moves to developing and evaluating programs or policies that address the problem and the determinants of the problem. And then it moves to the stage of assurance, or making sure that the programs, policies we define for solving the problem are actually implemented, are sustainable, and are continually being evaluated so that we make sure that what we set out to do is actually working and having an impact. So here's a classic example of public health. Back in 1854, a public health official named John Snow was looking at the outbreak of cholera in London. And he mapped the cases of cholera and noted an interesting fact. And the fact was that all these cases of cholera bunched together near one water pump, the Broad Street pump. Now, he could have gone ahead and had an education, a patient, or not a patient, but a public education campaign to make sure nobody would use the water. But in one of the first acts of public health, he did something very different, and he took the handle off of the pump so that nobody could use the pump. It's pretty practical, it makes a whole lot of sense, but back then it was a pretty novel thing to do. And that was really, and he followed that public health approach, right? He assessed the situation with data, he developed a plan of action, took action, and then checked to see whether it had actually worked. And he made history. He was one of the first true epidemiologists and really helped define the field of public health. Now, since then, we've seen multiple successes in applying the public health approach that has reduced infectious diseases or pestilence in the US and around the world. And we were recently, Kathy, you were at the Germ City display at the Museum of the City of New York, which I highly recommend. It was quite interesting. And they had a rendering of this particular drawing that was first published in 1935 by Charles Bolduan, who was then the director of health education for the New York City Health Department. And what it does, it shows the numbers of death per 1,000 population as recorded in the official records of the New York City Department of Health and Mental Hygiene. So a couple of things stand out on this graph. First, what really immediately stands out is if you look in the 1880s, 1832, 1849, and 1854, you see very high spikes that were indicative of the very high death rates due to cholera that really devastated the city. But what also jumps out at you on this graph is the dramatic decline in death rates, due in part to the tools, the traditional tools of public health. And remember, antibiotics didn't come along until, the end of World War I. So we were left to employing things like isolation, quarantine, good personal hygiene, use of disinfectants, and limitations of public gatherings to reduce these deaths due to a whole variety of different diseases. The last significant epidemic was the Great Influenza, the Great Flu of 1918. And so this was a much smaller peak in this graph of epidemics, but it still was quite devastating. In New York City alone, there are 12,000 deaths due to the pandemic, the 1918 pandemic flu, and it killed something like 675,000 people around the US overall. And it's interesting to point out, and the woman who was taking us through the exhibit made this point, that the rates in New York City due to the pandemic flu were not as great as you might have thought. 12,000 is a lot of people, but it could have been a lot more, if not for the efforts of the New York City Health Department, which is one of the older health departments in the country, and really had developed programs to fight the pestilence that was so rampant. And in fact, the New York City Health Commissioner tried to slow the transmission of the flu and was successful to a large extent by ordering businesses to open and close on staggered shifts to avoid overcrowding in the subways. Again, a very practical solution, which made a big difference. Now, of note, This was 1918, and that was the first year that both Douglas College and the Bloomberg School of Public Health admitted its first students. And there are accounts, I looked up to see if there were any descriptions of how Douglas College was affected by the flu, because basically the flu started, I think it was in the fall of 2018, and it was right at the time when Douglas was admitting its first students into the college. And the only thing I could find was reference to the fact that Mabel Smith Douglas helped care. She was a very giving person, and she helped care for students who became ill due to the flu, and as a result, herself got sick. Now, in many ways, the 1918 pandemic influence and its worldwide aftermath really jump-started the Bloomberg School of Public Health and its growth as a leading center of research and training in epidemic disease. Wade Hampton Frost was the first chair of epidemiology at Johns Hopkins. He was already a noted influenza expert, but when the pandemic hit, he was all on it, and he developed models for predicting and measuring epidemics, which to this day are taught in courses on epidemiology. We held a symposium just last year to reflect on the 100 years since the 1918 influenza pandemic. And it was very clear that we had learned a lot over the past 100 years, not surprisingly, and we learned a lot about how to assess and prevent pandemics, but the conversation of the symposium was quite sobering. And it was Tom Inglesby, who is our director of the Center for Health Security, who said, 100 years after the lethal 1918 flu, we are still vulnerable. Our public health infrastructure has indeed improved greatly, but without a universal vaccine, a single virus could result in a world catastrophe. And just think about, and this is a real concern of public health professionals, given the world has become so much closer together, that if we could easily be overcome and overrun by another pandemic flu, and it's of constant concern. So we're not out of the woods, and this is always on our minds, and you've read a lot about flu outbreaks over the last many years. But in addition, so the pandemic flu is one example of a public health issue, and back then it was all about, mostly about infectious diseases. But besides stopping infectious diseases, public health has had many other incredible achievements, and this is just the top 10 list from the United States from 1900 to 1999 that was published by the Centers for Disease Control at the turn of the century. And you can see that number one is vaccination, which is a rather sobering point to make, especially nowadays with all the anti-vaccination rhetoric that's going around. But I will also point out that motor vehicle safety is number two. And this is an area, as you heard in the introduction, this is an area that I've worked in for most of my career. We've seen tremendous improvements in road safety in terms of improved infrastructure, improved vehicles, better behavioral interventions to reduce drinking and driving, to reduce speeding. And that has really had a huge impact on the rate of motor vehicle crashes in the United States. But you can also see the other things that are on this list. And when these achievements are all put together, they collectively led to a dramatic increase in the US life expectancy. But it's interesting to see that this little spike here, this is how devastating the influenza epidemic was. It really made a huge difference in the life expectancy. But overall, over the past 100 years, life expectancy increased quite dramatically from 47.3 to 78.2, and that was in 2009. But when we compare our life expectancy with other high-income, well-resourced countries in the world, we do not fare all that well. This slide shows that in 2015, the United States ranked 28th in the world in life expectancy. And the public's health has has actually taken a turn for the worse in our life expectancy, since life expectancy has fallen over the last 3 years by small amounts, but it's going down as opposed to going up. This is quite dramatic and quite concerning. And what is particularly disturbing is that the U.S. continues to spend far more on healthcare and relatively less on other critical determinants of health as compared to almost every other developed country. So what we spend about $3 trillion in healthcare, 2.5 times the average of our industrialized peers, and yet Americans have shorter lifespans and fare worse in many, many health indicators, including obesity, vaccination rates, infant mortality, and life expectancy. Now, why is that? It's due to the simple fact that healthcare only determines about 20% of our general health. The other 80% is determined by the so-called social determinants of health. And these social determinants are the conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And again, let me just pause on this point, is that there have been studies again and again showing that, yes, healthcare is important, but it's only going to account for about 20% of our outcomes, of our health outcomes. And the rest of our health outcomes are going to depend on these other factors. So to tackle these complex problems, we really need to think about public health in a slightly different way than we've been thinking about it all the way along. Karen DeSalvo, who at the time she wrote this and coined the phrase Public Health 3.0, was the Assistant Secretary for Health and Human Services. And she coined the term Public Health 3.0 and challenged us to boldly expand our scope and reach to address all factors that promote the health and well-being, including those related to economic development, education, transportation, food, environment, and housing. And to do this, we need to embrace new partnerships that cut across sectors of society outside the traditional public health circles. And this is a key a message that I want to get across tonight, and I'm going to come back to that with some examples on the opioid crisis. It's in public health, we have been, when you think about the typical public health professional, you talk about the public health professional in a health department, working very, very closely with other health professionals. What public health needs to do, and is increasingly doing, is to work with people outside those traditional boundaries of public health, working with police officers, working with educators, working with city designers, to really have an impact on the public's health, and addressing these social determinants of health that are so critical to our health and well-being. Now, it's great to see some forward thinking that providers and health systems, and they're stepping up and realizing that they do play a role in measuring social needs and thinking about, well, it's not just about the clinical indicators and the genes that are going to determine the health of individual patients, but that they're beginning to ask about social needs and beginning to address these social needs. And that's been embodied by the movement towards patient-centered care and value-based healthcare, and that's fueling some very innovative programs around the country. But meeting individual social needs falls short of addressing community-level social determinants. So we often think about the determinants of health as sort of downstream downstream efforts and this is usually where medical care is situated, providing clinical care, providing medical interventions. You can go up midstream and you can start addressing individual social needs, including patient screening questions that ask about social factors and include social workers and other paraprofessionals working together with the patient to address these social needs. But it's only when we can go way upstream and actually improve community conditions and look at laws, policies, and regulations that create community conditions supporting health of all people. This is where public health is working all downstream, midstream, and upstream, but this is where we're going to have the greatest impact. And we really need to focus more attention there. Prescribing exercise and walking is different from changing a community to make safe walking spaces more available. Offering smoking cessation clinics is different than influencing the price of cigarettes or providing smoke-free environments. Both are needed, but again, what we need to do is move more upstream to really have an overall impact. So where are we and what are we up against over the next 100 years? Well, in this country at least, we have been successful in combating infectious diseases, maternal and child health problems, nutrition diseases, although new and emerging infectious diseases remain a threat, as I pointed out before. But what we're up against is a changing epidemiology, changing demographics. Our population is aging, leading to more chronic diseases. We're seeing a changing epidemiology of disease and injury. And we're faced with what people refer to as these new 21st century health problems that include violence, include the refugee crisis, climate change, opioid addiction, and overdose deaths. These are problems that are very different than the problems of cholera, smallpox, influenza. And I'm going to focus on one of these problems, the opioid problem, to illustrate a little bit further how the tools of public health can be used. But before I do that, I just want to take a bit of a detour, because most of my talk tonight is addressing problems that we're facing here in the United States. But I think it's important to point out, and it was a point that was really driven home for me in my travels recently to sub-Saharan Africa and then most recently to India, where these low and middle income countries are really facing a double burden of disease. So as you can see, and these data are from India, and it looks at the share of the global burden of disease that is attributable to non-communicable diseases, so chronic diseases and other non-communicable diseases, communicable diseases, infections, maternal, neonatal, and nutritional diseases, and injuries. And what you can see is that we've made tremendous progress, and it doesn't take anything away from the fact that we've been able to reduce communicable diseases, and in India, it's from 52% of the global burden of disease down to 33%. But at the same time, the share of the global burden of disease that's attributable to these non-communicable diseases has gone up from 38% to 55%. In the United States, the share of the burden that's associated with communicable diseases is, it's minuscule. Okay, so we've done a good job of addressing those communicable diseases. So we're addressing all these non-communicable diseases. Low and middle income countries are tackling both fronts. And it's concerning because people in these low and middle income countries are really struggling with fighting these non-communicable diseases. It was amazing to me in Tanzania, for instance, the rates of hypertension, the rates of obesity were equivalent to the rates of obesity and hypertension here in the United States. So this is a huge concern and something that we need to pay attention to. But I want to turn to the opioid epidemic. And again, this is just illustrative. It's a huge problem. It's a national problem. Areas with high opioid deaths in the country include rural, urban, and suburban counties, as we all know all too well. It was the opioid epidemic really hit home to me when I was giving my lectures in the principles of injury prevention and control, and I would give this lecture on the burden of injuries, and I would always start with talking about, well, what are the leading causes of injury, death, or what are the leading causes of death, especially in young children and young adults. And I would always start by saying, the leading cause of injury, death is motor vehicle crashes. And then one day, it just, and the leading cause of death in young people was traffic injuries. And then one day, it was totally different. And it was poisonings, and what was driving the poisonings? It was opioid overdoses. And by 2017, you can see there are 47,000 opioid deaths, far away more than car crashes, even guns. It just overtook these other leading causes of death. There are over 2 million Americans who are addicted to opioids in the country today. So what started the epidemic? I think many of you are well aware that it's tied in large measure to an increase in opioid prescribing. And that's due to one-time prescriptions post-surgery for too many pills. And I bet everybody in this room can think of a personal experience or the experience of a friend or a family member. You have minor surgery and you get a bottle of 30, 40 tablets. Crazy. Also due to the increase of use of opioids for chronic non-cancer pain, due in part to patient pressure and due in part to, a change in culture in medicine. At one point pain, they were saying it's the 5th vital sign and you have to address patients' pain, and we're always measuring pain. That's the first thing that you do when you come into your doctor's office now. They ask you to rate your pain on a scale from 0 to 10. And that's just, we swung too far one way, and now we're just overprescribing. And then also there's just out and out fraud in the pill mills. But we've seen a 3-fold increase between 1991 and 2010. The good news that we've made some progress in prescription opioids. There's been a 30% decline since 2011, and that's due to new professional standards, new CDC, the new guidance from the Centers for Disease Control, as well as a variety of state laws, in particular the establishment, the development of prescription drug monitoring programs, the PDMPs, which is a electronic capture of prescribing behaviors across providers. So if you go to a different provider and you need a controlled substance, they'll look you up in the PDMP and they'll find out that you were just prescribed that particular medication just last week. So that's helped a lot as well. So we've seen some progress made in this regard. But as the prescribing fell, the epidemic changed. And what happened was that overprescribing of opioids for chronic pain contributed to a surge in heroin and other illicit drugs. And what happened was both pure heroin as well as the fentanyl, which is what's that? Synthetic, that's the word I was looking for. A synthetic complement or a synthetic like heroin. They were made increasingly available. And as opioid prescribing has tightened, many people switched to illicit opioid sources. And now, totally different picture of the epidemic. Now, over 50% of opioid deaths in 2017 were due to street drugs. So what we started, we had a problem. We were looking at overprescribing, and we're throwing everything at that. And now, talk about unintended consequences. This is a great example of an unintended consequences. We thought this was working. We thought we were doing a good job, and then all of a sudden, the whole epidemic changed its character, and we have a huge epidemic related to heroin and fentanyl. Although the overprescribing still remains a challenge. But we do have a way of addressing this epidemic, and a key intervention is the use of medications for opioid use disorder. So the risk, there has been science that has shown that the risk of overdose deaths are reduced by up to 70% when patients receive treatment that includes approved medications, either methadone or buprenorphine. There are great studies out there that show that the use of these medications actually does work. And it contributes to population-wide improvement. This one study, this graph shows that in Baltimore, there was a 75% decline in heroin overdose deaths from 1999 to 2011 as access to treatment, both buprenorphine as well as methadone, increased. So these interventions work. They really do have an impact in terms of reducing opioid use disorder and opioid-related deaths in particular. However, there are gaps in access to these treatments. So less than 1/3 of those receiving treatment receive the effective medicines that can really help them. But fortunately, there's research that is illuminating new ways to make this treatment more available. And in particular, we've come to understand that we need to administer these medications at the point where folks need them. And two areas in particular are emergency departments and jails. So starting treatment in the emergency department, one study doubled the percent who were engaged in addiction treatment more than 30 days out of their jail term. I'm sorry. From the emergency department. So treating patients with buprenorphine in the emergency department, you can get them. You have to follow up with them, and that's the trick. You can't just treat them in the emergency department. There has to be a way for them to access additional doses of the buprenorphine, but it's a way to get them on the buprenorphine and really make a difference. And then also starting treatment in jail. So there was a study done in Rhode Island where starting treatment in a statewide correctional system led to 60% reduction in post-incarceration fatal overdoses. And this is a prime target population. You've got a lot of folks in the jails who are using drugs, injecting drugs, and this is a prime opportunity to get them off those drugs. But you gotta start when they're in the jail and again, follow up when they leave the jails. So again, we know what works, and there are a lot of other things that work, but we know treating with buprenorphine, methadone can work. We now are beginning to think, well, how do you make sure that people have access to these treatments? And as science points the way to solutions, developing partnerships to ensure widespread implementation of these solutions is critical. Some of our faculty at the School of Public Health have been working in particular, and this gets into working with partners and working with partners outside the traditional boundaries of public health. Our faculty are working with the police chiefs to define approaches informed by evidence for their departments. So they got together 6 police chiefs of some major cities around the country, and they met for a number of days. They went through the evidence, and they came up with recommendations based on the evidence and based on what they think could work. And you can see the list here. It's using naloxone, clearly, focusing on overdose deaths, educating on addiction and stigma. Stigma is a huge issue here, and we need to combat stigma among the police chiefs. We need to address stigma in the community. We need to address stigma in our own healthcare system. This is a study that some of our faculty in the School of Public Health, working with the health system at Hopkins, we're starting a big campaign to address the addiction problem in East Baltimore, and one of the things we're doing is we're putting together an anti-stigma campaign within the Johns Hopkins Hospital and within the Johns Hopkins health system, because that was a barrier to get the clinicians trained in using buprenorphine and being comfortable in using buprenorphine in addressing their the folks that are coming to them with an opioid use disorder. Also, partnerships and community engagement are critical ingredients to affect policy change. This is a picture of a group that our faculty put together, worked with in West Virginia. There were a number of folks who showed up, and together they developed a plan to combat the opioid problem in West Virginia, and it made it all the way to writing a bill and getting it signed by the governor. But these are the things that one has to do in order to take that good science that we've learned, that we've done with the research that we're doing, translated into programs and policies that are going to make a difference, and then implemented in the communities that need them the most. And we even sometimes work with lawyers. So we developed, with a law firm in DC, we developed a legal brief that documents the right to treatment in detention centers under the Americans with Disabilities Act and the Eighth Amendment. So these are the kinds of things to advocate for broader implementation of some of these programs. So this is just one example, talking about the opioid problem. As I mentioned, there are many other public health problems that need this sort of same approach that I've described. And we were very fortunate to, in honor of our centennial, we received a very nice gift from former Mayor Mike Bloomberg. And he gave us $300 million to help launch our second century with a focus on improving health and saving lives in the United States. And he said, listen, and he was really struck by the fact that our life expectancy was declining. So, this is not good. Now we've got to do something about it, number one. And number two, he has really become an advocate for the public health approach to solving problems. He's very vocal and very supportive of public health in general and the public health approach. But he said, I want you to focus on the 5 biggest problems. So we chose the 5 biggest problems from our perspective really needed our attention, and they were addiction and drug overdose for sure, environmental changes, including the effects of climate change on health, violence, including gun violence, but also suicide, domestic violence, obesity in the food system, as well as risk to adolescent health. More and more of our studies are showing that an increasing percentage of youth are disconnected from school, disconnected from home, which puts them at great risk for poor health moving forward. And one of the signature pieces of this program, so it provides us resources to hire great faculty, it provides us resources to do terrific research, but the real heart of the program is a scholarship program. So Mayor Bloomberg endowed 50 MPH, Master of Public Health scholarships, and 10 DRPH scholarships, Doctor of Public Health scholarships, every year. So this is an endowment, so this is in perpetuity. 50 MPH a year, 10 DRPH a year. Phenomenal opportunity. And this is not your traditional scholarship program. This is impact-based. It targets individuals working on the front lines in and outside traditional areas of public health. The fellows center their studies in a focus area, one of those 5 focus areas, engage with their home organization while they're doing their MPH or DRPH. Most of them are doing it part-time because they want to stay employed, they want to stay working with their organization, and they do their MPH or their DRPH part-time. And then they are obligated, because they got the scholarship, they're obligated to spend at least a year. Once they finish their degree, they're obligated to spend at least a year with the organization. But what this program does, it not only gets people who are really on the front lines and really tackling the problems that we care mostly about, but it also gives us the opportunity not only to bring a student in and educate a student, but work with an organization and bring the organization in as a partner in some of the solutions that we're trying to put forward. And these are just some of the partners that we've worked with in the past. It includes the traditional public health organizations like the Department of Health of Tennessee, but it also includes organizations like Earth Justice, the High Intensity Drug Trafficking areas of New York and New Jersey. And this year, we've admitted, and hopefully they'll come, but we've admitted 3 students from the International Association of Police Chiefs. So again, these are very, very different people. They're not, your typical public health folks, but we need them to work with us to solve these problems, because without that cross-sectoral approach, we're not going to really make a difference. So this is not going to be easy, and we have a lot of challenges. And some of the challenges are working in today's social and political context. We're seeing an increasing rhetoric centered on rejection of science in the formulation of public policy. We're seeing a disregard and lack of tolerance for diversity, and we're also seeing a resurgence of isolationism. And these are challenges that we need, that are going to make our job tougher. But we will succeed. And we will succeed largely because of the power of the people in public health. And these are just some of the faces. Susan Sherman is a professor at our school who works with the most vulnerable individuals in our community. And these are all people who are working in the area of drug addiction and overdose. Brendan Soliner, who's a young assistant professor whose interest is around looking at how we can change policies, healthcare policies, in order to make sure that the people who need these treatments get the treatments and in an affordable way. Belina Shaw is one of our fellows, and she is on the front lines of treating opioid addiction in Prince George's County, which is down the road from us. And then finally, my personal hero is Josh Sharfstein. So Josh is a former commissioner of health for Baltimore City, former state secretary of health for the state of Maryland, was at the FDA for a couple of years as a deputy commissioner. We were very fortunate to get him to come to the School of Public Health. He's our vice dean for public health practice and community engagement. He directs the Bloomberg American Health Initiative, but also is out there, again, on the front lines, working very, very closely with states and local governments and local organizations to, again, take what we know works and implement it in a way that's politically viable and feasible. So if you take this power of people and you add it to the power of science, of partnerships, of education, and the power of advocacy, we think we can make a difference. And this was the theme of a strategic plan for the school. And this strategic plan is going to provide a platform for taking us into the next century. And it's all about the power of public health. So just in closing, when you think about enhancing the power of public health, we know we can drive transformative change. We've done it before. If you look at our first 100 years and you look at public health as a profession, we've made enormous strides. So if we've done it before, we can do it again. And while the 21st century brings its own set of challenges, we can be successful by being true to the principles of science, partnerships, and advocacy. Public health education then can advance cross-sectoral solutions, bringing people together to achieve meaningful progress. And we really need to bring these other professions into the circle of public health and work with them hand in hand. And just in closing, it's clear that now more than ever before, leadership in the science and practice of public health is really critical for the world. And I will end with this last slide just to give a shout out to the School of Public Health here at Rutgers. Again, when I started, when I started out at Douglas, I just stumbled across public health. Because I was looking at graduate schools, as I mentioned before, and there was this one little fledgling course in public health. now there's a whole school of public health, and there's a very vibrant program providing, there's bachelor's degrees, but also graduate degrees. They offer an MPH and a Master of Science, combined programs, bachelor's and PH programs, as well as PhD programs. And they're growing. The School of Public Health was only established in 1983, but already they have 130 faculty and some 367 students. So the world has changed. It's great to see how public health has grown as a profession, and in particular how it's grown here at Rutgers and at Douglas. So I'll stop there, and I'm happy to answer any questions.